Corey, you touched on eating disorder. Did you have an eating disorder?
Yeah, so I was anorexic for a few years. I kind of forced myself not to react to feeling hunger. So I don't think it took very long. I would say a couple months. It was like, if I was hungry, the most I would eat would be like a slice of bread.
Mm-hmm.
And that would be like my food for the day.
Wow.
A lot of liquids. I also quit soda at the same time. So because it was all about weight. So I was like, I quit soda. I went to a lot of water, not much juice, usually water or milk, and like a slice of bread was like my nutrition. So after a couple months of doing that, it got to the point where I didn't really feel hungry anymore. So I just, even now, like recently just started, and it was like a new sensation, like a few years ago, where I was like, my stomach is uncomfortable.
Is this hunger?
Yes, because it lasted for a while where I would just be able to ignore that feeling. Like even if it, like you can't ignore the noises, like your stomach growling, but I'd be like, oh, maybe like it's not that I'm hungry. Maybe I just ate something my stomach didn't like or something.
Mm-hmm.
Like I would never relate it to hunger. So yeah, for a while I was able to just ignore food.
Wow. When in that sense, I think my ADHD actually protected me because I tried to be anorexic so many times when I was a teenager. I was a teen at the same time you were, like the 2000s, and everybody was super unhealthily thin, and they were the beautiful ones, and I was never able to have that body. So because I'm an impulsive person, I always ate, but I tried very much, but I never had bulimia and stuff. But I do have like selective eating disorder. So for me, the texture of things is very challenging.
Yes.
Like and it's insane because I like the taste, but the way it feels in my mouth makes me want to throw up. You know, sometimes I actually do throw up when I try something new because of that. Yeah.
There's one really interesting take on it that I have to share, but it's very, very interesting, and I don't feel we completely understand this yet, but anorexia is 4 times more likely in Ehlers-Danlos than in the general population, but bulimia isn't.
I'm Dr. Tom, psychiatrist, specialist in neurodiversity. I'm a neurodiversity advocate, and this channel has a clear, unapologetic stance in defense of neurodiverse people. No BS, no virtue signaling. Just solid, honest content, grounded in science, lived experience, and real-world relevance. If you're tired of cliches and want strong, actionable ideas that challenge stigma, clarify concepts, and empower neurodivergent individuals and allies alike, you are in the right place.
So the usual take we have on this is that why would the harder eating disorder be more likely than the easier one, like the lighter version, right? And we feel like Ehlers-Danlos is so closely related to interoception, proprioception, disturbance of your perceptions of hunger, temperature, bodily functions whatsoever, that it seems just really easy to be anorexic when you have Ehlers-Danlos and you're going down this route. So if you wanted to put it this way, bulimia would be an intermediate step, but anorexia would be like the final step that where you...
Yeah. Oh. At least like my experience with texture of food, I think would be very convenient if I didn't have to eat at all. Like, I don't know if you have this feeling.
Textures.
Yeah. But like, it seems a lot of trouble to eat, to go through the textures and stuff, and then have to throw up, which is a different texture in your mouth again. So maybe it has to do with proprioception.
Yeah. One of, the stereotypes of the anorexia patients in our clinic here is that they manage to vomit without having to put the finger down the throat. If you think about collagen is a disease, it's pretty obvious to see, and thinking about gastroesophageal reflux disease as well, it's pretty obvious that the esophageal sphincter is also somewhat defective.
Mm-hmm.
If you think about it, it's pretty obvious that Ehlers-Danlos disease might make it much more likely for you to be capable of throwing up without having to go through a whole lot. But I guess your texture thing protected you there.
Yeah.
You know,
And maybe that's the case for most Ehlers-Danlos patients too.
the whole flexibility thing, coming full circle with some things here. My uncle used to joke, if I jumped in front of a mirror and something moved, I wouldn't eat. That was my definition for like, I'm not skinny enough, I'm not thin enough, was like if something moved. And thinking about hyper flexibility and mobility, like my skin is a little bit more
exactly
flexible. So yeah, when I was anorexic, like I was bony. You could see bones in my shoulders and everywhere. But I never thought it was like, I mean, there's obviously worse cases. There's always people die from it. Like I wasn't the extreme, but I never thought I was so bad, because to me, I still was able to, like, I still had flexibility and like, and maybe that wasn't fat. Maybe that was
skin.
So,
And that was the criteria. You said that this is a joke between you and your uncle, but that was the criteria for us girls. Like, if you jump and anything moves, that's because you're fat. And anyways, the 2000s were really cruel with us, and now this is
sounds very healthy.
Yeah.
I want to go ahead and move on to how you diagnose hypermobile syndromes.
Because it said.
So what we do is the beighton score. That's BEIGHTON score, and it contemplates 5 joints. One really large one, that's the spine. 2 large ones, that's the knees and the elbows. And 2 smaller ones on your hand, that's the pinky and the thumb. For every movement that you can make as described, you get 1 point. If you score 4 or more, there's a high chance that you have hypermobility syndrome. The first one that we usually start off with is bringing your thumb to your forearm. You are entitled to push it with the other hand. So,
yeah.
Okay, so we got 1 for Corey, 1 for Carol, and 0 for me. No.
Can you turn so I can see? Oh, wow. Yeah, that is a big difference.
I'm very far off from you guys.
Wow.
And I gotta say that I do yoga. I don't feel like I will show you my yoga mat.
No, like even my hand, like all of it.
Really? And like.
Yeah.
Okay, even farther. Okay, stop now. Please stop hurting yourself. Why are you hurting yourself? Okay,
No,
it's because I asked you.
This is actually comfortable. Like.
Yeah, for me too. Sometimes
Okay, show me the other.
Dude, I do the dinosaur sleep. Yes.
Okay, that's cute.
The T-Rex sleep is what we call it. Yeah.
Don't you feel like your hands are slowly dying because of the lack of irrigation when you do that?
Sleep.
You know, when you sit, yeah.
No, like it honestly, sleeping like this is more comfortable. And I have to do both. So I like lock one in and sleep on the other.
Me too. Like this.
Okay, for either thumb, you get 1 point. Can you guys do the other one?
Yes.
Yeah.
Okay, so 2 points for you guys.
Here.
The next one is the pinky. You have to hyperextend the pinky, so you're pulling it backwards towards your arm again. Okay.
But I don't know how far.
90 degrees. You gotta go a bit further. Okay, awesome. Corey got it. And Carol got
I
it.
can't do the other side. Mine gets stuck.
Okay, so you're 1 point down. So it's Carol 4, Corey 3, and Thomas at 0.
Competition.
I got it first.
Is that where you enjoyed your hand?
No, my hand was here, but I wonder if the same incident, because I had a cast.
Might have shortened the tendon. Or,
Might have, yeah, because this one like really does not go.
Yeah, I feel like mine is almost. Yeah, mine is.
Yeah, yours is more than
Awesome.
But this one I can. Oh, that's fine.
Okay, moving on to elbows. What you need to do is you have to hold your arm out straight, and then you have to see if you can kind of push your forearm down so it will leave the axis of your arm.
What do you mean, like that?
Yep, you're doing it.
Like put
This
that
one
out.
Yeah, and then put your forearm down.
Like here, like here.
Exactly.
Oh,
Yeah, that's it. Exactly. So the formal criterion is 10 degrees. You both are comfortably within 10 degrees.
It was hard to follow the instructions because when I looked at you, looked like you're not doing
Yeah,
anything.
okay, yeah. I shouldn't be the one that shows.
Yeah, I don't know that I'm that flexible there.
I don't think so.
No.
Okay, so just for the sake of the fun here, Corey loses one other point. Can you do it on the other side? Yeah, no, that's clear.
Yeah.
So maybe not as far as Carol, but still. So you got 6 points?
From the other side.
Yeah.
I don't know if the other side.
Comfortable. Yep.
So 6?
You got 6 points, you got 4 points.
Okay.
Okay. I got 0 points. The next one is with the knee. So what you do is you just stand and you put 1 foot forward, and then you try to push the knee on your forward foot back as far as you can. The same thing has to happen that your your leg has to extend
A little bit.
beyond the axis of. So just seeing this profile, my knee is supposed to go back further. That's
I don't know. I don't know if I
It's hard to say.
like. Do I go straight up on this leg, or do I like lean down?
no, it's easier if you go straight up on that.
Straight up.
Yeah.
Okay, and then
Yeah.
push.
Can you see how it
I think it does. I don't know if you can see it from there.
I can
changes your profile?
feel it.
Yeah, you got it. Yeah, Corey, you got it as well.
Yeah, I can. Yeah.
I did both times.
Okay, so you got 8.
Yeah.
Corey
6.
is to 6.
Yeah.
Okay. The last one is putting your palms flat on the ground without bending your knee.
Oh, flat. I don't think I can do flat.
Carol's got 9 points.
Wow. Yeah, I can't do flat. No.
But that's because of yoga.
Here.
Okay, I can almost touch my fingers. My fingers almost reach the ground.
Yeah, I can
Really close. A bit of training.
Yeah, I can get
Yeah.
all my fingers down, but I can't get flat.
But if you do like 2 weeks of yoga,
Sure. And that was
it's so good to stretch out.
without straining. Like I wasn't trying to push. So
Right.
maybe.
So Carol's got the highest score.
Yes.
Hey, I'm not screwed on.
So if you didn't manage to follow our instructions, just look it up online. And it's pretty straightforward. There's going to be pictures.
And the idea is you only need 4.
Yeah, you only need 4. Every joint gives you a point. There's 9 joints we're checking.
So so our score wise, we are both
We
very
have
much
a clear winner
clear.
and a clear loser. Corey's got to train more yoga.
I was going to say you call yourself the loser in this, but you don't have to deal with it. You have the better health in this case. It's like my eye doctor saying that I have boring eyes.
Yeah.
It's because it's healthy.
It's Ehlers-Danlos spectrum, like ADHD or autism. Like you have different.
That affects that you have 13 different subtypes. Proves this pretty well, I guess. It definitely is a spectrum. But at least ignoring the exceptions, you need at least 4 points on a beighton score. And the main exceptions are that if you might have done high scores on the beighton score earlier, but you've hurt yourself, now you don't have high scores anymore. And then you need minor criteria too.
So could we use the scores to say that I have a more severe case of Ehlers-Danlos?
Not necessarily, no.
That was going to be
Yeah.
my question is like, so after doing the test and saying, okay, yeah, I passed this, I can be in the EDS category. What are the steps to figure out like where it affects?
Awesome. This is exactly what I wanted to talk about. Thank you for the great setup. So there's 2 major physical things that you have to consider that don't necessarily overlap. Well, they obviously do overlap, but they're not as necessarily relevant for psychiatric disorders. The 2 main ones are feigning and the artery dissection that we talked about. So when young people have myocardial infarctions, they either do that because they used cocaine or because they have dissection of the aorta or of the coronaries or of the vertebral artery or of the carotid arteries. So you need a cardiologist And you need a cardiologist.
Yes.
And I need a cardiologist for other reasons. But my wife is a cardiologist, so.
So you don't need a cardiologist. I already have one.
So she's coming next episode.
Awesome.
Doing all the examinations.
Right. We're going to use the podcast as self-examining.
So if you're young and you have EDS, you still should definitely get an ultrasound of your heart and the Doppler screening of your arteries and see if everything is in order, because you have special treatment, and there is even separate scorings for aneurysms. So there's one classical aneurysm that's usually rather benign. It's the abdominal aorta. Usually has aneurysms that you can just you could just check out every year through an ultrasound and see if it's increased in size. And if it does grow really rapidly, you have to treat it. Or if it goes beyond a certain number, I kind of feel like the number was 55 millimeters, but don't quote me on this. But you also get to do surgery, but those numbers are different for hypermobile syndrome.
Oh, really?
They're lower.
Are we endangered of exercising too much and then having a crisis or an aneurysm?
The quick response is yes.
Oh.
The longer response is depends on your physical state.
So I should stay lazier. No, I'm kidding.
You should
exercise on the right.
You should try to exercise specifically for Ehlers-Danlos.
Oh, is that a thing?
Yeah.
How would you do that?
So most importantly, again, it probably depends on what we're treating, but you can try to improve your vascularity. You can try to improve your intimate layer of your arteries through specific exercises. So what's most common is, the muscular pump of your feet, out of your legs, having that activated. And like Corey said, the gastrocnemius, like the calf raises he does, like no one else. It's probably a really good exercise because you're actually improving the vascularity of your arteries.
There's a saying that the calves are the second heart.
Yeah, that's awesome.
Yeah.
If you are prone to fainting, you should make sure you get the right amount of liquids. And that amount might be larger for you than it might be for regular population. And also get your electrolytes. So, we are just coming out of the era of hypertension. And we're coming out of it because companies and bakeries and restaurants agree that we shouldn't salt stuff, at least not as much as in the past. So usually here in Brazil, at least, you already get your freedom fries without salt, and you can salt them at the table. This is leading to more cases of fainting in the hypermobile population because they don't get the salt in. The fainting, the artery stuff, you have to have a cardiologist. But also those functional neurological disorders that are neurological disorders that don't have a clear substrate, don't have a clear cause. You might have dizziness or buzzing in your ear, or what else people would have called hysteria, somatic disorder. Those are also really classics. So we always double down on that. What you feel is real because you feel it. It doesn't have to be proven by science just because you're not there yet. Carrying us over to psychiatric disorders. What's most important in psychiatric disorders, but that's also obviously a real problem, a physical problem, is fatigue and pain.
Mm-hmm.
So the way you talk about what happens in summer in Brazil to you is very much a good description of what fatigue can do to a Ehlers-Danlos person. And pain is very multifaceted. So there's various presentations of that. That might be migraine, that might be endometriosis, that might be joint pain, that might be neuralgias, that might be stomach ache, IBS, irritable bowel syndrome, all of those. And we like to put those in the category of psychiatric disorders because fatigue and pain are two of the psychiatric confounding factors that we cannot treat well if we don't treat fatigue and pain. So let's say you only faint once a week, or let's say you only have like one heart attack per decade. That doesn't matter too much to the psychiatric comorbidity. It's basically just the cherry on top. But pain and fatigue, we have to approach. There's no way around pain and fatigue.
Yeah, because being fatigued and being in pain enables you to do a lot of stuff. Like I have a client who was diagnosed with Ehlers-Danlos and he's trying to look for a job. He also has ADHD, so we have this problem with motivation. He was going to this awful psychiatrist that said that a ADHD diagnosis takes like 5 years to make. And I was so pissed. I was like, no, you're not going back to this person. Like they don't know what they're saying. But anyways.
We got to specify that we're not talking about a medical desert. The person would have access to a provider, right?
Exactly.
So this is him talking to the provider actually rejecting.
Exactly.
I won't diagnose you. I need 5 years.
Yeah, to anything. Yeah. Just Ehlers-Danlos and fibromyalgia, which don't go together, and you can talk about that later. But anyways, and I was like, okay, shitty doctor doing shitty things. Let's move on. And he can, like this client of mine, just can't put himself through looking for a job because of the amount of pain and tiredness that he feels on a daily basis. So this is his whole therapeutic process, like us trying to move around fatigue and pain, but not be able to. But we are not going to move past these points as like if he doesn't take care of his physical health, so to take care of other aspects of his life that we need to address what's physical first, at least in his case.
There's this idea that you should go to your therapist to cure your fatigue and pain.
Yes.
But we really, really like to turn that around and say, hey, we need to treat fatigue and pain so we can take care of psychiatric issues, not the other way around. And I feel like this exists because people don't usually have a substrate for fatigue and pain. It's not something that's obviously altered in your blood work. So it's kind of like, this has got to be in your head. Talk to your therapist.
And there's also this negative self-judgment. Like, I should be able to do it. I should have the energy to do it, because I see my friends being able to get up in the morning and do stuff. And I cannot do that because I'm always in pain. So I'm a piece of shit. And you go into the spiral. And actually you have a physiological issue that you have to take care of.
I'm gonna, like we've talked about, like the autonomous nervous system, dysregulation, it is autonomy, the heart racing, the feigning, and all of the stuff that goes on, like in a regular Ehlers-Danlos patient. And that also means that we have a really good mechanistic model of understanding why those patients have such a high risk of anxiety. So within a given group of Ehlers-Danlos syndrome patients, we estimate 70% of those will have clinically relevant anxiety. That means that that's 22 times more likely than in the general population.
Wow.
So if your muscles in the arteries don't respond adequately to the stimulus and they don't contract adequately, and this might seem a bit off topic, but I swear to God it's not. If they don't do that, then your blood pressure is tending to be lower, right? So what the heart does in response is it beats faster. Mm-hmm. And what happens is unfortunate, because the heart beating faster doesn't mean it has more real output. So the heart beating faster makes the heart less efficient, actually. This is why people faint. And in Ehlers-Danlos, that's called the POTS syndrome, the postural orthostatic tachycardia syndrome.
Yeah.
So what happens is that you lower your blood pressure by having a faster heart. But it's not efficient because the vessels, the arteries, don't respond. Mm-hmm. But to have a heart that's racing, you need to have a higher output of norepinephrine, also known as noradrenaline, adrenaline. So if you need a higher output of adrenaline in your heart, at your heart, you're also going to have a higher output of adrenaline in your brain.
Yeah.
And that means that you're constantly high on adrenaline. And the consequence of being anxious is pretty obvious. But not just because of the de facto presence of adrenaline, but also because you now get to perceive your racing heart, and then you question yourself, I must be anxious because my heart is racing. So it's like you're putting like a 50% handicap on any Ehlers-Danlos.
But if you do that, if you go to that place, oh, I must be anxious because my heart is racing, you're already at like a person who is in therapy, because for most people, they just go through, I'm in danger, like I'm screwed, like this constant fear. I'm just edging up to what you're saying.
And that's awesome because the most frequent anxiety disorders of Ehlers-Danlos are panic attacks and agoraphobia, which is people that cannot leave the house anymore because they're so afraid. So it really is a fight, flight, freeze response. It's very adrenergic, very amygdalian, very reptilian panic response. I
wonder how it survived. Like, it's not like, the more I learn about Ehlers-Danlos, for me, it makes more sense that I had panic attacks when I was 10. This is why I first went to therapy. And I was bullied, and I was a fat kid, all of that happened, but also like knowing the association between those two things, if I could have had the clues were always there, that's what I'm saying. But also like the second feeling that comes up is like, oh, poor my clients. Those poor things, like people don't know, like we go through so much, like I'm okay, I'm used to it. I think I'm kind of over it, as an adult. I have the repertoire to deal with it, but there's so many people struggling with that and living like they're in danger just for lack of knowledge.
There's the joke or stereotype of like surviving on stress.
Yes.
That's what we did.
Yes.
We were always anxious, always stressed out. So that's how we lived. That's how we survived.
At what cost?
Sure. Yeah. Yeah, but we didn't know that. That was the thing. Right. We were like, oh, we need to have this in order to survive. So it was like when I wasn't feeling stressed and anxious, I wasn't feeling motivated.
Yes.
Because I needed that anxiety to push me to do something, which is the opposite of good.
Good quality of life.
Right.
That's a good example why we feel like ADHD is also, well, we know that ADHD is also more likely in Ehlers-Danlos and hypermobility than in the general population. So we usually say that ASD is a bit more likely than ADHD. So it's about 7 times more likely for ASD, autism spectrum disorder, and about 6 times more likely for ADHD. But yes, there also is an overlap. It might just convene and it's 6.5. Anyways, so the whole motivation stuff and getting this anxiety and the racing heart and the interpretation and the narratives that you make of that. Obviously, considering ADHD as a disorder of motivation, reward, makes it pretty obvious that you need to feel something physical to...
Either interest or anxiety, right?
Right. This is why people self-medicate as well with energy drinks and caffeine.
To make themselves anxious, to
Exactly.
have the motivation to do something.
Exactly.
Yeah, because the energy effect, we were just talking about that beforehand, right? Before we start here. I personally don't get energized by energy drinks.
Maybe the deadline works for you. That's also something that people do, right? They just wait it out, and then it's due tomorrow.
Yeah, that's what's happening to rewriting my thesis now, doing the correction.
So congrats, you're using a panic response to write your thesis. That's awesome.
That goes to what I've said in other episodes where like that's not the reward situation, that's the punishment. You wait until that last minute because you're like, I have to do it or there's something bad. Mm-hmm. So you're not motivated by a reward or by anxiousness. You're motivated by avoiding your punishment.
So the mechanistic model that we propose by Ehlers-Danlos, and so maybe it's important to say that maybe I should have brought this up earlier. We're not saying that Ehlers-Danlos necessarily causes those. We don't say that ADHD is secondary to Ehlers-Danlos. We know they coexist. We know they overlap. We see the reasoning. We have the mechanistic model to understand why it happens, but we're not saying one causes the other necessarily. But they definitely do coexist. So, and makes it much more likely anyways. But what we usually go for to explain why ADHD would be more likely in Ehlers-Danlos is because of the hyperarousal, like the constant adrenaline in your brain, and the accompanying fatigue. So you constantly bounce around between being crashed out on the floor, not being capable of getting off the couch and staring in the wall 24 hours, and it's due tomorrow.
Mm-hmm.
I gotta spend the whole night using Vyvanse and coffee.
Well, and that connects to what you're saying with your client about the job search.
Yeah.
Job searching doesn't have that
Deadline.
right. You could maybe fake one and say, "Oh, I need a job by this day where I'm not going to have money to survive." But you're kind of you're making your own deadline. It's not an actual outside source, so it's that's hard.
Moving on really quickly, so we get this in another episode, but maybe we'll do 4 more episodes on ASD, on EDS. So we also have a mechanistic model to understand why ASD, autism spectrum disorder, would be more likely in Ehlers-Danlos. And we usually relate those to the changes in interoception and sensory understanding. So as we touched on when we were talking about your eating disorder, you might have a hard time of, or at least you're at least modulating the way that you perceive hunger, heart racing, pain, temperature. And the fact that you're doing that differently kind of already describes before ASD criterion, which is the hypo or hyperreactivity to stimulus, right? And within this different perception of your own body, you also have a different perception of the other senses. So if you have like the strobe light, that's probably always going to be the go-to, flashing really quickly, you cannot manage to focus on anything else. So this probably touches a bit on as well on the fact that they overlap, but not necessarily a causal. But you can easily see how that describes a person with ASD, right? The sensory overload, just not because of outside stimulus, but also because of the inside stimulus as well. So you really have a hard time self-regulating. So that's why stimming helps a lot. That's why EDS probably is more likely to stim as well, right? Stimming through pain.
Yeah, we do things that he thinks is painful. The whole time we've been here, we've been doing like movement, and he's like freaking out.
Yeah.
It's like, no, it's just us like being comfortable and like moving around.
No, just stretching.
And if you think about that, that's also the before criterion, you know, like thinking about pain and the way you respond differently to what should be painful. If you think about ASD and ADHD and how we function with ASD and ADHD in day-to-day life, you guys are already aware of the perfectionism and the trying to control everything, you know, that control freak. This is very much OCD, obsessive compulsive disorder. So that also makes OCD more likely because you have to control stuff all the time. So maybe just to illustrate through Corey, I'm going to talk about Corey because it's easier.
I think that's something you said in one of the episodes too.
Sorry.
No, please. Yes.
The fact that he knows that his ankle might be unstable, and the fact that he now focuses on strengthening the other muscles around and tendons around, it gives you control, gives you actual control, but that also means that you have to constantly have the idea of controlling stuff. So that leads directly into OCD and also directly into the one disorder that's very closely related to the one personality disorder that's very closely related to Ehlers-Danlos Syndrome, which is OCPD, obsessive compulsive personality disorder. Basically a consequence of all of the above.
Yeah. Can I just add a few things? At least when we are working with contextual behavior and sciences, we don't look at behaviors isolated from their context. We always look at the function. So how do I know that working out my calves is a symptom of OCD rather than just something that I have to do to take care of my health? It depends on which purpose it serves. So if you're doing that because you need to feel, because it agrees with your values of taking care of your physical health so you can do the other things that are important to you, this is not an OCD issue. But if you're doing that because you have superstitious beliefs that by doing that you have control over things that you do not control, this is more likely to be OCD. So just just so our viewers and listeners don't think that if they're doing one specific thing, that means that they have OCD or PCD. It depends on the frequency, the intensity, and the function that this behavior has.
I'm pretty certain that actually Corey was a calf model for sock photo shoots.
Feet are too big for that.
That's the issue with this phrase, right?
Maybe you should have gone into swimming after all.
Thank you for watching. Please hit that subscribe button to get notified of our next video.